are. So hopefully you can see the slide set, and what we can see is that we've got, apart from myself whinging on, we've got a large panel available to answer your questions. So the idea is that we're going to be interactive. In the Q&A box, please feel to put in your questions, and we will probably try and answer them as we go along. And in the second half of the talk, we will get to really put the panelists on the spot. So it's great to welcome Di Loudon, our GP, who, given most of the audience are probably GPs, will be able to hopefully help us answer the questions that are burning for you if you're too shy to ask them yourself. We've got 2 cardiologists and 3 chest physicians, if I don't count myself as a cardiologist, but the chairman today. So Boon Lim is an electrophysiologist, Ramzi Khamis is an interventional cardiologist, Susannah Bloch, Brian O'Connor, and Onmin Khan are respiratory physicians. So you've got a large panel to help with any questions that you have. So who are we? We all work at 1 Welbeck on 1 Welbeck Street. We're the chest team and the cardiology team. Di is a Chelsea medic. So you can find us on our website, which is listed up there. So the order of play will be my introduction, which we're into already, the current evidence base from Onmin Khan, some of the key features that we might be talking about with Di, and then into chest pain with Ramzi Khamis, breathlessness with Susie Bloch, palpitations with Boon Lim, and cough with Brian O'Connor. And then after that, absolutely anything you'd like to ask us. So the idea is to work out what the worrying red flag symptoms are and what the very comfortable green flag symptoms are when we get to that session. Before we do that, I'd like to say that we, although are very happy to manage the very long COVID if we have to, acute COVID is not what we're doing, because we don't have all of the PPE to look like Ramzi did in that picture over there. And we do not want to see those patients if they're acutely unwell. They obviously would not be best managed as an outpatient facility. So a brief introduction to COVID. What it is not is obviously Chinese flu, just like Spanish flu was never anything to do with Spain. It's not bat flu, because the bats were not really to blame. And it's not the flu, because it's far more serious than that. I'll remind you that SARS, a previous coronavirus, came from bats to civets and into man and killed some. And then MERS came along, actually had a higher mortality rate, but thankfully was much more contained, from bats to camels, where it stood in a reservoir for many years before exploding into man. So COVID-19 apparently has come from bats, and maybe is a modification of a pangolin virus, which has a 96% match to the one that's trying to infect us all. And of course, spread is because its R0 is about 2 to 2.5. So it's quite infectious, much more infectious than influenza, not as infectious as polio, which is about 6. And if we can get it down to less than 1 by spreading out, which we are trying to do, then the spread stops and the numbers go down. The diagnosis, as you know, is by a swab. If it didn't hurt, then they didn't do the swab properly. And now by antibody testing, and we may come later to what a positive antibody test actually means. I'm still not certain it means you're immune to anything, and an antibody may become negative over time in any case. This data is taken from our World in Data website, and actually summarizes quite nicely the increase per million of the population, and the United Kingdom even ahead of the United States. And it also mentions a case fatality rate. Now, the case fatality rate is a slightly tricky term. We probably want the infection fatality rate, because there may be a lot of cases that don't have very many symptoms, but it is what it is, and unfortunately we're at the wrong end of the scale for that either. What we're sort of good at, and until I looked at this data, I actually was having a go at Boris Johnson, is that we are testing per 1,000 of the population more than most other places in the world. Is it still the right number? Because if you look at on this graph, the number of tests conducted per case found, then what is the right number? It's down here at the moment. The WHO feels that if you're finding only 5% your test positive or less, you're probably in the right level. If you're finding 10%, you probably aren't testing enough. So as we round up this section, I'd want to talk about the case fatality. Now, Italy and Iran seem to be doing very badly still. New Zealand doing extremely well down there, and the UK is about just under 5% mortality. And as I say, the 5% mortality rate, case fatality varies with time. It can be overestimated if there's a lot of community infection that's not tested, and underestimated if we test a lot of what we know are normal looking people. And the infection fatality rate is harder to assess. So with that gabbling on finished, I'd like to hand over to Onmin Khan to summarize some of the key facts that we have about COVID as we approach lockdown number 2. Onmin.
So good evening, everyone. I'm actually going to focus quite closely on what treatments there are now so that we can demystify some of this if we may, and just to explain some of the rationale around it. So So this is a horrible slide which is meant to confuse everyone, but basically it lays out the rationale for some of the treatments that you may or may not be familiar with already. And at one level, we have antivirals, which include favipiravir, which is a novel antiviral agent, remdesivir, most of you have heard of, and then Kaletra, which is, as you know, protease inhibitors for HIV therapy. So that's targeting the virus itself. Then we have drugs such as chloroquine and hydroxychloroquine, which also disturb the way the virus may replicate. So hence, there was a lot of interest in this earlier. And then finally, drugs that target the immune response. And if you remember, you get the infection, and then on average, 5 or 6 days later, everything starts ramping up in terms of a cytokine immunological overreaction. And that, we believe, is obviously a really important factor in terms of how someone reacts. So believe it or not, this is the list of things we can use currently or potentially. I've put these in italic just to explain these ones have been studied, and basically, at least in hospitalized patients, don't have any effect. And then there are interesting ones like inhaled nitric oxide and favipiravir, which are going to be, I think, potentially important antivirals. And then we've obviously got the world of convalescent plasma monoclonals. So what's the story with hydroxychloroquine? Well, unfortunately, despite all the kind of initial excitement and lots of people, including Trump, using this and the Brazilian presidents, this, in terms of hospitalized patient in the largest UK study, which is Recovery, and the WHO international study showed no benefit of relatively high dose hydroxychloroquine. There was a problem, if you remember, originally, because people were combining this with azithromycin. And again, azithromycin is still of interest, but certainly in terms of the large studies, WHO as well as Recovery, there's no evidence of efficacy. And then Kaletra was obviously another interesting group, and Recovery, which, as you know, is a UK-wide study launched from Oxford with many thousands of patients. Again, Kaletra, unfortunately, showed no evidence of time of discharge, nor, for that matter, survival benefits. So another drug that didn't appear to kind of behave as we might like. So remdesivir came along, and this study is the one that's mainly been used to license the drug in the US and certainly in Europe. And this showed a median recovery time, which was 10 days for a remdesivir versus placebo. Now, the thing it failed on was mortality. So this was the kind of bottom line, and I won't bore you with the kind of detail of it, but basically, again, in hospitalized patients, some advantage in terms of duration of illness. And it's a potent inhibitor of SARS-CoV as well as even MERS. And these are the kind of classic graphs they showed in a New England publication. And what's interesting is this effect was only really beneficial in those who are receiving oxygen or non-invasive ventilation. So if you were not receiving oxygen, this drug made no difference. And finally, this is the WHO study, which then is the largest, in fact. So this is the Solidarity WHO study. The drugs in this group, and I'm going to go into the evidence base of some of them. Again, there was no reduction in mortality in any of these groups of drugs. So that includes remdesivir, hydroxychloroquine, Kaletra, interferon beta, which is an innate interferon which should help your innate immunity target virus. So remdesivir is still slightly open. It's expensive. You have to give it intravenously, so it's not exactly going to probably answer everyone's request for this globally, and it is debated as to whether it has any significant mortality outcome. You should know there are lots of studies going on, including ACTT and WHO solidarity studies. All these studies are platform studies that are recruiting to try to look at different modalities. So the other big promise initially was tocilizumab, which is an anti-IL-6 monoclonal antibody. And unfortunately, again, this in the larger study by Roche didn't show any efficacy in terms of primary and secondary outcomes. So we're really not there with host-directed therapies neither, except for this. This is our good old-fashioned dexamethasone, and this is from the New England publication. It made a difference in terms of mortality. So the only drug so far that makes a difference is, in fact, good old steroid. Cheap, very historically useful. Again, it's not really, again, helpful for people not receiving non-invasive ventilation. Okay, so it's kind of useful, but in the more severe end of the patients. And similarly, this is REMAP-CAP, which is a UK-wide ITU study. It showed some benefit, but again, once the recovery study published the dexamethasone study, everyone had to stop recruitment, and it became standard of care. Similarly, WHO performed a large meta-analysis of all the current studies, which there are 7 trials. And again, steroids, it seems to be a classifier. It doesn't really matter what you use. You use a glucocorticoid steroid of any type, and it seemed to have mortality reduction. Just to point out, the research kind of world has exploded. These are just a list of things that I don't need you to go into the detail of them, but just to tell you there are things varying from using antiplatelet agents, anticoagulation, to signaling pathway immunological targets, to newer antivirals. There's also something called a recovery RS, which will be looking at non-invasive ventilation and whether that versus high-flow nasal oxygen versus standard high-flow oxygen Venturi mask type approaches will result in a better outcome. We really don't know the answer yet, despite all the excitement about using CPAP machines. These are the outpatient studies, which are ongoing already, and this is just a small selection again. So I think the world is trying to move to early therapies in terms of antivirals, which hopefully will stop people getting worse. But obviously, vaccines are another huge field. So that's really my summary, and I hope that's at least given you an overview. I'm afraid, so right now, for mild patients, we don't really know the answer. We know certainly they're hospitalized, IV remdesivir will shorten your duration, but we're not sure about mortality. Steroids certainly should be standard of care if you're severe enough to require oxygen or level 3 care. Thank you.
Thanks so much, Min. We're going to probably save the questions to the end and move on to Di Loudon. So Dr. Di Loudon is an experienced GP, and we wanted not just hospital specialists, but someone who's at the coalface to tell us what the important questions that we might answer. So thanks for coming, Di.
Thank you. So I think in primary care, we're through the first wave, but certainly the second wave is bringing more and new challenges. The obvious one is remote consulting, which is mushrooming. I think the GP appointment study showed in September 2020 about 38% of consultations are now telephone consultations, and that was only 13% in September 2019. And they are difficult. You can often only see the patients, sometimes hear the patients. So the history is really important, and it'll be really useful to get some tips on what it is we need to be asking to pick up that serious pathology, but also what investigations we need to do and how we access them. The other difference between the first wave and the second wave is with the first wave, the focus was really on COVID. All screening was suspended. But in the second wave, we've got COVID, we've got all our usual GP workload, so cardiovascular health, asthma management, as well as the winter illnesses. But the final challenge is probably this sense of urgency. And certainly we're seeing it a lot at our practice. And just going back to that GP appointment data, in September 2020, there were 1.8 million more same-day appointments compared to September 2019. And I think that's in part patients during the first wave didn't want to go to hospital. I think they were afraid to go. The hospital infrastructure, lots of appointments were cancelled. And so we're seeing patients present later. The other things we're seeing is management of the COVID patients. So, and they're often very sick. And certainly at our practice, we see those patients, they deteriorate, and then we send them up to hospital and they're discharged. And it will be really useful tonight to get some kind of specific criteria. What is it for admission? Is it oxygen saturation 94%, 93%, 92%? And also if you risk stratify those people. So if we get a call from somebody who's a male over 60 with hypertension and diabetes, does that make a difference? The other potential challenge, which has been in the media quite a lot, is this maybe the spilling over of secondary care into primary care. So if patients need to be discharged back to the community, what is it we need to be looking out for? What are they, you know, what do we need to know about who needs to be readmitted? But I think what's fantastic tonight is we've got GPs and specialists all together, albeit remotely, obviously, so that just to help us really best manage these patients during this challenging second wave.
Thanks so much, Di. So I think it does put it into context. There's a lot of people doing a lot of work. So to try and answer some of those questions, Dr. Boon Lim is going to go next. We almost lost him, but he's managed to come back. So Boon, thanks very much. We can't quite hear you yet, Boon. I think we have a muting issue.
Yes, I'm unmuted. Iqbal, can you hear me now?
Thanks.
Okay, thanks. So thank you, Iqbal. So in the spirit of this red and green flag, I think it would be useful to talk about palpitations as the other panelists will also talk about all the other things, including shortness of breath and cough, with respect to red flags and green flag symptoms. So when confronted with a patient, one of the questions to ask, whether it's remote consultation or whether you're seeing the patient face to face, is whether the patient needs to attend accident and emergency. And the three major points that I would say with respect to palpitations are as follows. Firstly, if there is an abrupt onset palpitations associated with syncope or extreme dizziness. Secondly, when palpitations are sustained and are associated with significant chest pain. And thirdly, when palpitations are associated with extreme shortness of breath. And it can be somewhat difficult in a remote consult to know whether or not what the patients consider as significant. And here is the challenge with remote consult, because you have a judgment call, and if the patient's call more.
So Boon's signal has disappeared. Can I get one of the others to let me know if we can hear? What I might do, Boon, is just pause you there because I think we've lost your signal. And is it possible to come back to Susie? So Boon, I'm going to pause you.
When
Okay, so I'm afraid there's a signal issue. So so Rupal, you may want to just contact Boon and get that resolved while we move to Susie.
Hi, can you hear me now?
Oh, yes.
I'm so sorry, I just cut out from my phone. So the second type of red flag, I'd call red flag 2, is when should patients make, when should I make an urgent referral to cardiology? And in my view, this is when significant palpitations are occurring frequently and impairing quality of life. For example, recurrent A&E admissions and missed work. Palpitations with structural heart disease, and this could be ischemic heart disease, heart failure, for example, in which the patient may not do very well with decompensation if they are in a sustained arrhythmia. If a patient has a high risk of stroke, and this is when you assess the CHADS-VASc score, and if the palpitations are very suspicious of atrial fibrillation or flutter, this is a reason to make an urgent referral to cardiology, or as I'll come along to very shortly, to get a diagnosis made as soon as possible so that anticoagulation can be initiated if we can detect atrial fibrillation or flutter. If there is a family history of sudden cardiac death associated with a patient developing new palpitations, it is a reason to refer for an urgent cardiology clinic, and an abnormal ECG if you can get one on a patient. So the green flag palpitations would be, for example, most commonly seen in my experience in long COVID, are palpitations which occur with standing and resolve with sitting on lying. And this is a question you have to ask the patient. And if you ask the question in a particular way, you may get this answer. So the patient who complains bitterly of palpitations all the time needs to be asked very carefully about what they do to make the palpitations better. And in a cohort of patients, I've seen 15 to 20 patients now, because I also run the tilt table service. I just want to share with you very briefly what a tilt table test might do. So this is a tilt table test in which you can see blood pressure. In this example, 140/80 with heart rate. And here are minute bars, 2-minute bars for each of this. And after 5 minutes, the patient is tilted upright. The heart rate goes up by about 10 to 15% here. The blood pressure is not very much changed. At 20 minutes, we give glycerol trinitrate to vasodilate. And this generally leads to a reactive sinus tachycardia to try and maintain the vasoconstriction because you've created vasodilatation. This is another patient who has long COVID with significant symptoms of palpitations. And these are the group of patients who, on standing or sometimes having a large meal or when exercising, are easily fatigued and get palpitations. And this is one of the things that we're starting to see very much in our tilt service, which I run at Imperial. So this is the baseline heart rate. And after 5 minutes on tilting, you can see the immediate rise in heart rate from 65 to 110. And after that, this oscillatory pattern in the blood pressure starts to occur. And these oscillations in heart rate are mirrored by blood pressure oscillations. So the heart rate here is between 82 and 120, typically on a 10-second cycle, which are mirrored by a systolic blood pressure, which oscillates between 80 millimeters mercury and 120 millimeters of mercury within a 10-second cycle, fluctuating cycle. It's no wonder the patient feels fatigue, brain fog, headaches. Some can trigger migraines. And generally, I would consider this a very sub-POTS phenotype. So orthostatic intolerance with an adrenergic surge with reactive sinus tachycardia that can explain a great degree of palpitations for specifically long COVID. And these are typically associated with the other symptoms that I described. The other group of green flag palpitations are palpitations which have occurred since the pre-COVID era, i.e. continuing long-standing palpitations, not entirely worsened by COVID. And the key management here is to really do get or try your best to get a symptom ECG correlate. Easier said than done. And of course, the focus should be on anticoagulation on patients with clearly documented atrial fibrillation or flutter with a chest VASC of 1 or more. Now, there are a group of patients who I'm seeing more as well with rare palpitations who describe a sudden extra skipped or missed beat, typically followed by a strong beat, which follows on itself from a pause. So these are very likely to be atrial or ventricular ectopic beats. And it's very common after a chest infection or an infection such as COVID for the autonomic nervous system to trigger more such ectopic beats, i.e. the frequency of long-standing ectopic beats may increase, and that will give you this kind of flavor of palpitations. Once again, an ECG symptom correlate is key. So the top diagnostic tips, I would say, is teach patients to self-palpate, radial pulse, or even the carotid pulse. They can all probably buy an Omron M2 or M3, which costs 30 to 40 quid on Amazon, or A&D, which are all validated brands for blood pressure. And I do tend to trust if it's repeatable and a heart rate flag that says consider atrial fibrillation. Obviously rule out anemia, thyroid abnormalities. And of late, I've had a lot of patients come to me with the AliveCore mobile device and the Apple Watch. And I must say the quality of the 2-lead ECG on these devices, I believe. There's a clear PQRS T wave here, and there is a clear PQRS T wave here, which you can download, or the patients can download on their iPhone as a PDF and email to you or print out and give to you, and you should be able to make the diagnosis. The last thing to say is we can now use remote diagnostic halters. So patients no longer have to come into a center to have a halter fitted. We can now send halters out to your patients, posting them out and getting our physiologists to explain to your patients how to fit it, and they can then post it back, and we will be able to diagnose usually an arrhythmia and even suggest a management plan for these open access halters. And I'll stop there. Thank you.
Thank you very much indeed. So I think in the interest of time, we'll probably move on, but just to highlight that we're a non-COVID site, obviously, but offering remote testing like Boon has suggested is a great way of trying to sort things out. And I learned a lot from Boon in how to manage these palpitations. Most importantly, stop the caffeine, take 2 liters of water, add a bit of salt. So Boon, I have learned from you. So let's move on to Susie, who's going to talk about breathlessness. Thanks, Susie.
Hello, so I'm Susannah Bloch. I'm one of the respiratory consultants from Imperial, and can you see my slides? Can somebody give me a thumbs up? Iqbal's nodding at me. So I'm going to talk a bit about breathlessness and what we can do remotely, and then, as Di asked for, particularly some very key points about when breathlessness is worrying. But as this was called COVID Mark II, I thought I'd just start with a tiny bit about why COVID causes breathlessness. So breathlessness in COVID and all the mortality secondary to COVID is mainly caused by respiratory failure. So breathlessness and assessing it is a really key thing. As Onmin said before, it tends to be a sort of 2-phase illness, and the breathlessness develops at day 5 to 10-ish. And if your patients are saying to you, I was unwell with a bit of a flu-like illness or whatever, and now I'm breathless, that's when you need to start worrying, okay? So they've moved from the early phase, and now they're in this hyperinflammatory, hypercoagulable cytokine storm release phase. And that's when they start to develop an ARDS type picture. And that's when you need to start worrying. And that's the top X-ray there. The other thing that happens and causes breathlessness in COVID, but we think it happens a bit later, but it's been the cause or thought to be the cause of several of the sort of stories that you hear about sudden death in a patient who was initially getting better, seemed to be stable, had a stable oxygen requirement, then suddenly developed a PE and died, and that's because of the hypercoagulability. So these are some things that we now understand a little bit more about COVID and why we're particularly worried about assessing breathlessness, okay? And then following the acute phase, we move into a sort of prolonged phase about where you develop a fibrotic process in the lungs, secondary to the ARDS type that we would see in other causes of ARDS, but there's also thought to be a sort of organizing pneumonia. And then, of course, patients can get a bacterial infection on top. But what Di was asking for, and I think is really key, is who needs to be admitted, and what are you going to ask the patient when they're calling you or on a video consultation about to establish who needs to come in and who doesn't. So I think the really key things for me are they breathless at rest? Okay, because being breathless at rest is a very bad sign. Or if they walk to the bathroom, does it take them more than sort of 2 minutes to recover? Is that really pushing their limit of their exercise tolerance? If this is happening at day 5 or so and it's getting worse, again, that's more worrying than if they're just knackered at the beginning, or if they're maybe 3-4 weeks down the line. And then another important thing, and talking about risk stratifying, was thinking about patients with other risk factors. And there are various different risk factors that we think about when we see somebody in A&E. So, and they're obvious and what you'd think about anyway. So really high-risk patients are those who are immunosuppressed, who are on active cancer treatment, who are pregnant with other comorbidities, anything like that. Then moderate risk things, and I think we're going to share these slides as well, so I'm not going to run through all of them. But then moderate risk things tend to be if you're older than 70, a bit of CKD, ischemic heart disease, and then the other things are obviously if you're obese over 55, which seems quite young, and if you have from a BAME ethnic background as well. The other things I think are really important are frailty and vulnerability. So because this disease can change quite rapidly, if you're concerned that the patient doesn't have support at home, we want to see them in A&E, and we'll have a lower threshold for admitting them then. Then the hard things you can do to sort of from the history to the examination. So most patients, or a lot of patients now, have bought their own oxygen saturations monitor on Amazon. Some of them work, most of them work, and I think, as Boon was saying, you can trust them quite well. The important thing with those is to remind the patients that they won't overread. So they're not, if their SATs are saying 98, the SATs are 98. They won't overread. They may underread, but they're not going to overread. Okay. So if your saturations are less than 94% on air and you are an otherwise normal, healthy person, that is very worrying, and you need to at least come in to be assessed in A&E. If your saturations drop by more than 3% on, well, in A&E, we do a 1 minute sit to stand. So basically a patient just sits in a chair and stands up and sits down as many times as they can in a minute, okay? And it's not so much about how many times they can do it, it's more about do their saturations drop? And we do that in A&E all the time, and it's actually quite a nice test. You can all go home and practice it as well. And then, so if you've got low SATs of less than 94, if your saturations are dropping by more than 3%, if you've got an ongoing fever that is not resolving, that's worrying as well. And if you're unable to talk in full sentences, and you should be able to assess that even on the phone. If the patient is so breathless they can't explain their problems on the phone, then we want to see them in A&E. And then other things are tachycardia and tachypnea as well. When they get to A&E, what are we going to do? We're going to do some bloods to risk stratify them. We're going to do a chest x-ray to see if they've got widespread shadowing or no shadowing. And we're going to do an ECG to look for any sort of cardiac complications as well. So what happens after that? So one of the things that Di touched on is that patients often get sent in because you're quite rightly worried, and then we might send them home, and we're moving our targets all the time. And one of the reasons why we're moving targets is bed availability, so that the targets do change. So I might be saying 94% to you now, but if we go into a major surge again, like we did before, we were sending patients home with SATs of 92 and hoping for the best. Things I think will be a bit different this time because we know about dexamethasone in particular and also remdesivir. So we're going to have a lower threshold for admitting people because this time there is something we can potentially do to help. Your patients in A&E should have had a swab to prove that it definitely is or isn't COVID. They should have documented observations that they can come home and tell you, you know, I had SATs of 95 in A&E, so they said I was fine. They should all have had bloods, a chest x-ray and an ECG. And if they haven't, send them back in and tell them I told you to, because some patients were getting sent home really without full assessment. I think it's perfectly reasonable if you're worried about your patient at home to send them back in again if they've been sent home from A&E. They may see somebody else, the situation may have changed, the A&E doctor may not have fully fully appreciated what's going on at home. And so I think send them back in again. Better safe than sorry. And I think even now that we do have more treatments, even more so, better safe than sorry. We ideally, and the criteria for discharge are quite stringent. So you shouldn't really send somebody at home unless they have a support system at home. So somebody who's vulnerable and frail, but doesn't meet any of the other criteria, we'd still want to have them in hospital. We'd really want somebody to be off oxygen. sending somebody home with a new prescription of oxygen for an acute, potentially fatal viral illness is quite a no-no, I think. But it does occasionally happen, particularly in people who are really taking a long time to recover, and particularly if we get into a bed crisis again. We want them to be improving, and we want them to be nicely into the improving phase. And because if they're in their first peak, we want to make sure that they're not going to go into the second phase when they get home. There's a lot of talk about remote monitoring and remote hubs, both pre-admission. So some patients you may find are being sent to some of the central hubs, which aren't up and running as far as I know at the moment, but were before. So remote wards, sent home with an oxygen monitor if they don't have one. They need to have a telephone, and the team will check in on them every day and have a low threshold for sending them back in. And then once patients have been discharged from hospital as well, they may be kept an eye on remotely as well. It's important to remember that this is going to take a long time to recover. 80% of our patients at 3 to 6 weeks post-discharge still were symptomatic with abnormal imaging. I can probably rambling on, but very briefly, long COVID syndrome is something we're going to come across a lot more. Again, what you need to know is which patients we want to see and which ones we want to reassure. These are the definitions, and you're all aware of the big range of symptoms that long COVID can cause. The second and most common one that patients complain about being shortness of breath. Long COVID, we don't really know why it happens. It's very common, affecting probably about 10% of people. So it's going to become more and more of a thing. And at Welbeck, we're looking to set up a service so that we can assess these patients and give them a really good initial assessment and a plan to move forward, so that they have maybe not long ongoing management, because unfortunately insurance companies may well not fund that, but an initial assessment and a place to go from there. Why are they still breathless? Did they have a PE? We need to make sure that they didn't have a PE. If you think your patient is genuinely still breathless, they need to have a CTPA. Why? They may have ongoing fibrosis. So we need to have the CT of their chest, different sort of CT. But the point of referring these patients in is to ensure that there isn't a long-term sequelae or damage in the lungs or the heart, to make sure that there isn't something that we can do something about. And then hopefully from that, we'll be able to reassure the patient, give them some techniques such as the pacing, planning and prioritizing that you might use in something like chronic fatigue syndrome, helping them to explain all of these things and then take it forward on their own. We've also got a whole gang of wonderful physiotherapists who can help us. This, I don't know if you guys have seen it already, but it was published in the BMJ. It's a very nice long COVID in primary care little summary, which I think is useful and addresses all the things. As Boon was saying, with these patients who have little tangible that you can put a finger on, it's really important to have a holistic approach and make sure that you address what's concerning the patient. Otherwise, you'll lose their trust immediately. And then it's a no-win situation for everybody. But actually, what about the rest of all the causes of breathlessness? Obviously, I don't have time to tell you about all the causes of breathlessness and everything, but what can we do remotely? Actually, we could do a lot more remotely than I thought we would be able to do. And I think we're getting better and better at assessing people remotely. I use a mixture of a telephone call and video consultations, depending on what the patient wants and whether I actually need to see the patient. There's some things you obviously miss with a remote consultation, and we would always bring a patient up if we actually wanted to see them. And assessing people's performance status prior to cardiac surgery, I think you actually need to look the patient in the eye. Obviously, you'd want to listen to some people's chest, other people you're happy just to go on the CT scan. But at Welbeck, we are open and we are keen to have people in for investigations. They need not to be actively infected or actively infectious, and there are screening questions, and some people are having swabs if appropriate, but there are CTs, lung function, echo and everything, and we can arrange all of those for any cause of breathlessness or any of the other symptoms we're keen to see. My main hat is as the lung cancer lead for Imperial, and I think it's overly worrying what's happened to the 2-week wait referrals. Patients, unfortunately, are staying at home. I know that you guys are keen to refer them in, but I think we need to get the message out there. Not all coughs are COVID, not all breathlessness is COVID. All those other diseases still exist and they still need treatment. Certainly, although it's going to be a struggle this winter, but we want to keep seeing those patients. And yeah, this is just a picture of what happened to the 2-week wait to referrals for our trust, not lung specifically, but all the conditions. So it's worrying because presumably all those lung cancers are still out there, just haven't been diagnosed. And that's it. Thank you.
Susie, thank you very much. It's worrying and heartening in equal measure, and I think all hospitals this time around will be doing face-to-face consultations, because there's some things you cannot do without looking at the patient and touching them. So Ramzi, we're now going to talk about chest pain. Historically, Ramzi has examined his patients in detail, and I've been less touchy-feely, especially with patients with chest pain. Perhaps I should learn something from Ramzi. What am I going to learn from you, Ramzi?
Thank you very much, Iqbal. I don't think I can teach you anything, especially with the beautiful beard you have there. You look very wise. I think, you know, I'm looking forward to learning more from you as the beard gets bigger. So, well, thanks for the introduction. I'm learning a lot. I've learned a lot from Onmin, Susannah, Boon, and definitely from Di, and I'm glad I'm here. Thank you for having me. So I'm a consultant interventional cardiologist at Imperial, but I'm also a scientist. I'm a BHF clinical senior lecturer, and I'm the clinical lead for the high-risk atherosclerosis and cardioimmune clinic. But for you, importantly, I work at One Welbeck as well. So I'm going to talk about chest pain and COVID, and I won't go through the pathophysiology, but the cytokine storm is a big deal, and that's kind of causing all sorts of trouble to the heart, including making the atherosclerosis more vulnerable to rupture, increasing myocarditis in a vicious feedback loop, etc. So kind of, you know, peeling away from the pathology, the question that Di wanted to know is, how could I tell if the chest pain is cardiac, respiratory, or muscular, or not worrying? Well, it's all down to the history. So examination is one thing, but history is very, very important. So same as usual, if it's tight, central, and radiating, you've got to think that there's a coronary problem there, and you can't rule that out by just taking history. Is it pleuritic? That could be pleural, pericarditic. Is it sharp, non-relenting? Could be PE, could be pneumonitis from the COVID. Is it positional? If it's positional, could be pericarditis, could be perimyocarditis. Is it exertional? Exertional also could be coronary, but also COVID-related pneumonitis can give exertional chest pain. We've seen that a lot. Be aware that if the patient has risk factors for coronary disease, do not rule out the fact that this patient is having a heart attack. And I spent a lot of time and effort in the first wave working with the BHF, running a campaign educating people, is that if they get typical heart attack symptoms, not to ignore them and to present we're still there. And on a more kind of chronic pathway, if in doubt, just refer and test. So I'll talk first about acute coronary syndromes, because that's very important, and that's acute severe chest pain with or without hemodynamic decompensation. Type 2 MI could come with sepsis, with COVID, with an imbalance between oxygen supply and demand, and type 1 MI with plaque rupture causing a myocardial infarction. The worrying thing, as you were talking about, and Susie mentioned a bit, is that we had this excess death in the first wave, and you know, we were worried that any visits dropped very sharply to start with. And I'd like to encourage your patients not to be shy to go to A&E or call 999 if they've got severe chest pain. And I hope that this time around that you know that we are there for you. We are in the hospital. We are waiting for the heart attack patients, and we are capable of dealing with them safely. So please do not be shy to say to your patient, look, call 999. And we don't want to be missing heart attacks like we did in the first wave. So moving on from that, this is our data from Imperial from the first wave, showing that actually out of the first nearly 500 patients we saw, quite a lot of them, about 40% of them had a raised troponin with myocardial injury. And actually having myocardial injury was a very positive risk factor for mortality. The odds ratio was about 2.4. So if you had a positive troponin, you were much more likely to, unfortunately, end up not alive at the end of the event. And hypertension was another one with an odds ratio of 1.88. So this is kind of, you know, from the very severe first month of the first wave. So I'll come on to that, to another acute presentation, which is myocarditis. And that's appearing acutely in COVID-19 patients several days after initiation of fever. And really the most common presentation is persistent and fluctuating chest pain, mainly immune mechanisms, as we discussed, and it can be accompanied by respiratory failure, hypoxia as well, and driven by that. The main thing that you want to get in these patients is a 12-lead ECG to differentiate between what you can see here in the top ECG, which I'm sure all of you have recognized, ST elevation, myocardial infarction, anterior laterally with some Q waves there as well. So this is a late presentation MI in COVID where I ended up revascularizing in LAD, but maybe a bit too late. The patient did well. Versus the ECG down below, which is of myocarditis with the upsloping STs there and PR depression. I mean, you know, the ECG gives you a huge amount of information, and the visit to any, even if you just get a 12-lead ECG, is important enough. Blood tests are important, as Susie said, and we've got our Imperial kind of protocol on how to anticoagulate and how to do it. I'm happy to share that at the end as a document. But, you know, the tests that we use acutely that drive, you know, in the cardiovascular domain that kind of allow us to risk stratify patients are D-dimer, troponin, BNP, CRP, full blood count, LFTs, and renal function. And what we know now is based on the ISA React data and the Italian data that the risk of mortality increases with you know, observations being deranged as per the table here, age being increased, but also with the CRP more than 100, ferritin more than 300, and the troponin more than 28, with a D-dimer more than 1,000. So these are important tests to have if you're worried about the patient. So what can we offer here at Welbeck? Well, I mean, we can offer all sorts of things, but I'm going to focus on the things that we use in chest pain. So with echocardiography, you can tell what the LV function is. You can look for pericardial effusions. You can look for pulmonary hypertension, for right heart strain. This is a real patient from the first wave that presented post-COVID to me at Welbeck. And this is a Welbeck echo. And you can see here, this is the left heart. You can see mild left ventricular dysfunction, but also you can see that the right heart is pushing against the septum due to the patient having pulmonary embolus. So, you know, even with the echo, I could tell that this patient, you know, has something seriously wrong with them. The CT scans that we can offer are amazing. So with one scan, we can do a CTPA, a CTCA, coronary artery, and CT aorta. But also we can now do a dual energy CTPA which is equivalent to a VQ scan to look for small clots. And you know, this is also a real patient from last week who came in post-COVID, and you know, the coronary arteries were normal, but from the same scan, I could tell that the patient has very calcified aortic valve. And also from the same scan, we could tell that the lungs has COVID-specific changes, even though this is 6 weeks post-infection. And also at the same scan, you can look for a PE, which he didn't have. So, you know, one scan and lots of answers, and that just takes a few minutes here at Welbeck. This is a scan of another patient. One of the attending GPs in the conference now referred to me, and here you can see from the one scan, she was getting some breathlessness and some chest pain, and this is pneumocystocele post-infection, post-COVID. Another scan from a patient here also at Welbeck. This is the dual energy CTPA, and you can see here in the arrow the lack of perfusion in the lungs. So we can really tell a lot using CT now. We also can use cardiac MRI, and this is another patient of mine as well who had an MRI post-COVID, and you can see here that there's lots of things you can see on the MRI. You can see the lung changes. You can see that in the heart there is again the D sign in the myocardium with the right pushing against the left, and there is a bit of late gadolinium enhancement there showing myocarditis. So the MRI is very useful as well and can give us a diagnosis. Long COVID, as a disclosure, I'm advising NICE on long COVID. We've just submitted the first consultation with their remit of the long COVID guidelines that will be coming out later this month. But the symptoms are persisting symptoms of chest pain, breathlessness, palpitations, dizziness, pre-syncope, syncope, and tachycardia. And if you want to read more about it, you can Google my name in long COVID. And I gave a long interview to Medscape a while ago about the cardiovascular aspects. Also the BHF, which is, by the way, the best charitable organization in the world by far, has a very good page on this, talking about long COVID, what it is and what you should do about it. And the link is here to tell you more about it. But the bottom line is, it is real. It's a syndrome. We're working on the NICE guidelines. Patients are suffering with it even 6 months post-infection, and we need to know what to do about it. A lot of the pathology that we're finding in post-COVID patients, we can find on the scans and the modalities that we've showed you, and also Boon showed you beautiful tilt table testing on the autonomic dysfunction that these patients suffer from, and also Susie talked a little bit about the lung issues. But really, together here as a multidisciplinary team at Welbeck, we can really dig deep and start treating these patients, investigate them properly. So thank you very much for listening. Email me, call me, or WhatsApp me if you like. My number is here on the screen. So is my email. And I hope that we all get through this phase unharmed. I really would like to take this opportunity the night before lockdown to wish you all good health, and really wish your patients good health as well. And thanks for listening to me.
Thanks so much, Ramzi. We learnt a lot from that, and no idea why you're not a professor yet, Ramzi. So let's move over to Brian to talk about cough. So Brian, tell us something about cough and related to COVID and not, obviously, red and green flags. We can't hear you yet, Brian.
Yes, good evening, and thank you very much for asking me to participate. I guess most of you will know who I am. I'm a test physician, a bit long in the tooth at this stage, but still practicing in the private sector. And my talk is focusing on my experience of COVID referrals and COVID potential referrals in the private sector since March. And I guess the overriding theme of my talk is that don't forget that all that coughs is not COVID. Now, you will have seen detailed information about various aspects of COVID and how it affects, how it impacts on cardiologists and respiratory physicians. But in primary care, there are a range of symptoms, of which cough, fever, and dyspnea are the dominant ones. And of course, it took us a while to cotton on to the fact that loss of taste and smell were also features. But of course, when COVID hit the scene in April, I saw an awful lot of patients who had symptoms compatible with COVID, but in reality, they had hay fever because they had cough, they had a bit of wheeze, and they had disturbed sense of smell and taste, and they felt feverish. So bear that in mind. In terms of red flag symptoms for COVID, when do we worry about a cough? Well, the obvious and most common thing to worry about is coughing up blood, because that, of course, could be indicative of a pulmonary embolus. But in reality, patients who you see in primary care, they're exposed on day one, and it takes somewhere between 3 and 10 days for them to manifest their symptoms. And as we've all heard, the vast majority of patients, thankfully, are mild. And I have to say, I've primarily seen those at the milder end of the spectrum, not being at the cutting edge in the NHS working in COVID clean environments. Having said that, I've had about close to a dozen patients who ended up on ITU who came to see me afterwards. And interestingly, in the context of long COVID, and this may come up in questioning, all of these patients made an extraordinarily good recovery and didn't 4 months later have any symptoms of long COVID. But why are we worried about cough? Because of course, the big killer in relation to cough is whether it could be leading on to pneumonia. We talked about the various manifestations of COVID infection, whether it be mild, moderate, or severe. And you'll have heard from Di Loudon what GPs require. They require some knowledge of how the patient is doing. And then Susie Bloch gave a wonderful, wonderful summary of what the patient, how we should assess patients, whether it be remote or otherwise, using an oximeter. But the fact of the matter is, using an oximeter, if the arterial saturations fall below 94%, we know that we're heading towards a more severe illness. And of course, if they desaturate on minimal exercise, we're heading towards a more severe illness. But again, for most of us dealing with our face-to-face patients, irrespective of their age or indeed their vulnerability, the cough may or may not be a manifestation of COVID, and we do have to think of the alternative. We still have to think of influenza. We have to think of, do they have coexistent respiratory disease? Do they have bronchiectasis, asthma? Have they been smokers, COPD? And don't forget that at this time of the year in particular, one of the infective illnesses that can masquerade COVID very closely is Mycoplasma pneumonia. This is what NICE tells us about monitoring and managing patients with COVID. It's not hugely helpful. They talk really about using honey and codeine phosphate, or if cough is very severe, morphine sulfate, and to be aware that vulnerable patients are at risk of being unable to clear their secretions, and this can lead to downstream pneumonia. And of course, this is practical advice in the sense that we should encourage our patients to avoid lying on their back and preferably to lie prone. The other issue for us, again, I guess, is when a patient has a cough and a fever, do they have COVID-19 pneumonia or do they have bacterial pneumonia? And whilst what I've highlighted here on the slides is all very good, in reality, it's extremely difficult to make that distinction. And as I said, many patients will have coexistent sinusitis and may have loss of sense of smell and taste. Mycoplasma can mimic COVID-19. I mean, a barn-door bacterial pneumonia is very straightforward and easy to diagnose. But if you ask me, and this may well come up in Q&A, what do I do with a patient with a cough and fever? I still play with the same straight bat as I did a year ago, but bearing in mind that COVID is there in the background as a significant differential diagnosis. And I must say, I am inclined to intervene early with antibiotics. The antibiotic of choice for me is azithromycin. So how are we evaluating patients with possible COVID-related chest infection? For the symptoms, the at-risk group, and you've heard about the vulnerable groups. We look at their arterial saturations. A chest X-ray, I guess, is a routine, fairly straightforward test. But if you're worried about incipient respiratory failure, you'll obviously refer on, and we may well be inclined to CT of thorax. You've heard of the cardiac manifestations and the ability to remotely monitor ECG. And again, in the context of long COVID, a lot of my patients with long COVID do have persistent cough. They have low-grade breathlessness, chest pain, and I invariably end up performing echocardiogram in addition to ECG. In terms of the acute COVID, of course, monitoring acute phase inflammatory markers, C-reactive protein, D-dimer, serum ferritin, these are all markers of potential deterioration in COVID status. So if they've got a very high ferritin, if their D-dimers are elevated, notwithstanding the thrombogenic potential, we have to be aware that these are patients who could be deteriorating. Just briefly, because I'm the last talk of the evening, and I want to have plenty of time for question and answer. I want to just remind us that guys who are at risk of COVID, the group are elderly, obese, immunocompromised, patients with background severe cardiovascular disease, renal impairment, patients with type 2 diabetes, even type 1 for that matter, and of course underlying established respiratory disease, whether it be bronchiectasis, chronic severe asthma, COPD, long history of smoking, or indeed fibrotic lung disease. And you'll have heard a lot more about all of the other risk factors. One other final slide, a shout out for our physiotherapy colleagues, because both in the acute scenario and in particular in the long COVID recovery phase, in my experience, my physiotherapy and rehabilitation colleagues are absolutely key to recovery, because an awful lot of our patients, for reasons that were outlined again by Susie, we don't find a reason, we don't identify very much, but yet 10% of our patients are extremely compromised. And in much the same way as we manage chronic fatigue, we have to embrace a holistic approach towards managing the long COVID patients, of which I have to say respiratory symptoms dominate. Thank you very much for your attention.
Thank you so much. And I think hopefully the audience, which is large, agrees that we've had a very good session, but it's not over. There have been some questions. And so if I might start with you, Brian, because you're still warmed up. The idea of a peak flow or a spirometer, which I'm sure some GP practice have, is that a dangerous thing at the moment with COVID around?
Controversial, isn't it? I mean, I do peak flow and I consult on a face-to-face basis on the grounds that one puff into a peak flow machine 2 meters away from me when I'm wearing a mask. I don't see that as a risk. Our lung physiologists, certainly at the Cromwell and at 1 Welbeck Street, would want to have a negative corona swab before they would engage in performing spirometry or other more detailed lung function tests. It is perceived as an aerosol generating procedure, measurement of lung function.
Yeah, okay, I would think that as well. Everything seems dangerous these days. Susie, if I might come to you, Brian mentioned quite a lot of what the physiotherapist would do. A long time ago, in the first part of COVID, I had got my in-laws and my parents blowing balloons up as home physio. Have I got to the wrong part of Google there, or was that a good idea?
So blowing balloons up, I'm not sure I heard about blowing balloons up. Our physios give patients a bottle of water and a tube to blow bubbles through the water. I guess it depends on your balloon. A balloon might be a bit hard to blow up. You want to do a gentle PEEP maneuver. You don't want to burst any blood vessels. But yeah, any sort of self-chest physio, and that's the whole idea behind proning, to try and open up and avoid atelectasis in COVID, because what the problem is if you get a bit of atelectasis and then that lung doesn't ventilate, then you sort of turns into a vicious spiral. So anything you can do if you're unwell to make sure that your lungs are continuing to aerate would be a good idea. Sitting out of bed, even if you're feeling awful, tell your relis or tell your patients to get out of bed, sit out of bed, take a few steps every couple of hours. Really important. Deep breath right into the back of your lungs. And I think blowing up a balloon or blowing through some water would probably be a good idea as well.
Although I've got a question for...
Oh.
Yeah, so I'm just going to step in and ask a question to Susie, if that's okay, Iqbal, which is following on from that, there's the inspiratory training and expiratory training. Which of those is more important? There are things like Power Breathe that one can buy from Amazon to give you that resistance on inspiration. And then there's the concept that Iqbal raised and that you said, blowing out in a balloon, I think forces expiratory training. Are both of those equally important, or do we know about physiology of lung expansion to get rid of basal atelectasis? Because these are things patients could do at home, for example, for free.
So both, you want to do both, because that's what, yes, you need a bit of inspiration and a bit of expiration. I don't think there's any firm evidence to say that the forced expiratory or forced inspiratory maneuvers are any better. I embarrassingly only found out about 18 months ago that those ascensive spirometers with the little balls, you suck, you don't blow. Who knew that? Lots of people, but not me, unfortunately. But yeah, so you want patients to do both and anything is better than nothing. And there is no firm evidence. You do have to be a bit careful that they're not hyperinflating and at risk of causing any sort of trauma, because of course there's the whole school of thought of patient-induced own lung injury, which is part of the thinking behind why CPAP may not be such a good idea and why ventilation may be better, and with barotrauma and things like that. So you don't want people to be doing too much or hyperventilating, because in fact you might cause damage, make things worse than better.
That's a really clear answer. Can I move over to a question that's come from Fiona Butler and to Ramzi, our cytokine expert. So Ramzi, are there any indicators where there's a mild illness and then suddenly you're going to get that storm that actually, to be honest, if I might reveal, you sort of suffered as well earlier on in the year. So so are there any markers that we know of that would predict that illness, biomarkers or other?
Yeah, that's really interesting question. So not everyone that presents with acute severe COVID ends up with the day 8 to day 14 cytokine storm, and actually it looks like ethnicity is a good marker. So if you're BAMI, especially Middle Eastern men mainly are a lot of the sick people in the Middle East. As you know, I'm involved in charity work in the Middle East, and so are you. But I'm now advising on quite a lot of patients with really bad cytokine storms. They recover day 6, day 7, and then day 8 to 14 they get hit really badly with that, and it seems ethnicity is a big deal. We don't know why yet. Sex, so it seems that men more than women are getting the cytokine storm. Comorbidities as well, so hypertension, previous lung disease as well. Now the thinking about endotheliolitis, generalized endothelial infection and long COVID relates to this, because if you do get the cytokine storm, it seems that you are embedding endotheliolitis, and that might be the hypothesis that we're working on the science side, on the science lab side, is that the pan-endothelial infection might be causing an interruption in the feedback loop to the autonomic nervous system via the vagal nerve, and this is kind of Boon's area really, but it seems like it is that. So the vessel reactivity because of the endotheliolitis may be causing the secondary autonomic dysfunction, and lack of compensation kind of interrupts all the loop, and then you're getting long COVID. So it seems that people that are getting the cytokine storm are also getting longer term symptoms. However, the most recent study on long COVID is showing a different demographic. A lot of the long COVID patients are women, white women in their 40s, 50s, and 60s. So still so much to explore, loads to explore. We still don't know exactly what's happening. ONMIN runs the post-COVID MDT that I take part in sometimes. There's always a cardiologist in the post-COVID MDT, and we've discussed these issues before. It'd be good to get ONMIN's opinion on this. Actually, he's more of an expert on it than I am.
Yeah, thanks, Ramzi. I think maybe the question is around, have you got any biomarkers as well as the epidemiological risk factors of mild COVID and progressing to a cytokine storm? And I suppose in part, some of the blood tests do help you there. I mean, there are very few proper prognostic studies, but certainly on the ground, and I think just in terms of a very small number of publications, there is some correlate to things like cell death, raised inflammatory markers, your lymphocyte count at the point you present. So for instance, if you have a very high ferritin, which is evidence of high inflammatory state, then and let's say a troponin rise, a D-dimer rise, all these things don't necessarily mean what we traditionally took them to be. They're kind of non-specific biomarkers. So I think if someone's got a relatively mundane blood panel, I think one would guess that this person's not going to progress. Whereas if they got shockingly high numbers, that should make you at least pay a bit more attention.
ONMIN, I haven't seen any data from our acute IL-6 assay that we started doing. I don't know whether you've got visibility on that.
No.
No, okay. So we do now have an IL-6 assay available at Imperial on our guidance. So that would be really interesting to see whether an early IL-6 rise might predict a cytokine storm later on. It's possible. I mean, it might be an early indicator that there's more coming. And a lot of these cytokines are in a positive feedback loop. You only have to release a bit of TNF in the system to stimulate a whole load of others coming up.
So Fiona, I think the answer there was that it's about the demographics and all the biomarkers aren't quite validated yet. After that science, I need a cold shower. Boon?
Can I just ask a question?
Oh, yes, Brian, before we go to cold showers.
Exactly, but if you're a family doctor and you're dealing with a person and you're worried about them deteriorating, is the message not that if you check on day 5, day 7, inflammatory markers, ferritin, D-dimers, troponins, or whatever it may be, as Unmin has said, and if they are elevated, well, then that just increases your anxiety levels and lowers your threshold for referring to hospital. Because I think that's really what we're trying to get across to Di and her colleagues. How can they pick the ones that are going to go off as opposed to not? And whilst high markers don't mean cytokine storm, certainly, as Unmin has said, normal blood tests are very reassuring 5-10 days into the illness.
Okay, no, thank you. I was going to try and deviate slightly away from COVID, because I know that Boon has recently taken to very cold showers and feels invigorated. Boon, why are you doing that?
Wim Hof, if I tie it back to what a cold shower can do, and really I'm reading this in the context of a cohort of patients which I see as the lead for the syncope unit, and a cohort of these patients have the condition called POTS, which are very difficult to manage. Tying this into COVID and actually picking up on IL-6, which I want to come back to, the cold shower hypothesis is a vascular training hypothesis, Iqbal. So if I remind you about the ischemia reperfusion study that inflated a blood pressure cuff during the myocardial infarctions, because we were depriving vasculature of the blood that would flow in that forearm, for example, we're essentially doing the same thing when we have a cold shower. And then when we release all these ingredients within the bloodstream, some of which we can't measure, I'm sure, which includes nitrous oxide, there is an effect that comes back to the heart. So I think Wim Hof, who is the Iceman from the Netherlands, does not express it in these terms, but there is a science around cold showers. Some of you may have heard in the BBC in the last 2 to 3 weeks that they were talking about a cold shock protein being released in groups of elderly patients who used to take the Christmas baths or the New Year's baths. And these are very invigorating experiences. So I've just finished the Wim Hof method. I can now hold my breath for 2 minutes and 15 seconds on the exhale. And I tell you what, it is really energizing. And when I have a cold shower and come out, the lowered body temperature in the evening helps with sleep. And this ties me in to sleep. So Ramzi, when you go to sleep, IL-6 reduces. And there are several studies on sleep. And it's also one of my interests that if you get your patients with adrenergic surges or constant adrenaline highs, which some of my POTS patients cohort have, to live cooler, to not use a 13.5 TOG duvet, to turn the temperature down to, say, 16 to 18 degrees, they have a much better night because they're not roasting on the duvets. And these are very helpful for syncope patients, very helpful for POTS patients. And I suspect in the long COVID cohort with orthostatic intolerance, with reactive adrenergic surges from the low blood pressure, low blood filling state, this is going to be an avenue of signs, almost mystical signs that we might be able to explore. So if you can't bear a cold shower, then I think an ice bucket, ice immersion in your hands and your feet may well do the same thing. And I'm looking to experiment on this in my tilt lab. So there you go, 2 minutes on cold showers.
Now Boon, that is spectacular. And I'm
happy to volunteer, Boon.
So Ramzi's taking you up to stop his IL-6 And it must be why all those people swim in the Serpentine when it's absolutely bloody freezing. So with that, I'm going to do a wrap up because I think we've had a spectacular session and I've tried to learn as much as I can from here. So let me share my slides again and see if we can get a wrap up. And by all means, everyone butt in if you think I've got it completely wrong. So we've had the idea about COVID-19, and I think Onmin's covered the fact that there isn't really any proven community treatment, but maybe steroids when you're as sick as a dog already would help you. So we've covered some of the palpitations, chest pain, breathlessness and cough. And I sort of took away from the palpitations that pre-syncope, syncope, dizziness, chest pain, breathlessness, and an exertional sort of symptom would make me think red flag and make you think red flag, so you can refer in. In terms of breathlessness, Susie highlighted some key numbers, and certainly at the start of COVID, I bought a oxygen saturation machine, and I bought one for my in-laws as well. My parents were out of the country, so I couldn't buy one for them. So I think that is useful. And of course, if they can't talk and they desaturate quickly, that's a worry. And I also took away the fact that I hadn't fully mentated that 80% are still symptomatic 3 to 6 weeks later. And then with Ramzi and chest pain, I think obviously coronary artery disease with recurrent chest pain, just like their angina, you're going to worry about that. If there's breathlessness, palpitations and syncope with your pain, that's obviously important. And even COVID itself can cause pain for many reasons. So that was useful to know. And then in terms of the cough, then Brian highlighted that ruling out pneumonia is key, but that can be difficult. I think if there's a fever, they're very breathless, they're anosmic, then you begin to worry it might be COVID. And then of course, coughing up blood, that's not hard to worry about, is it? Coughing up blood. And I liked what Brian said about all that coughs is not COVID. I'm going to use that. We have a long COVID sort of seminar coming up. It's obviously becoming a very interesting and developing field. And I think there's going to be a lot more to say about it. But I think it's probably more than one disease, and probably at least 3. Something more chesty, something more autonomic-y, and maybe even something neuromuscular-y, if I can use that bad English. And of course, there is an element which patients have already talked about, which is the post-traumatic stress. The symptoms cause the anxiety, not the anxiety causing the symptoms. So as we've mentioned, it is important to take them seriously or you lose their trust. And of course, we are going to finish this seminar by having a very cold shower, which is going to make us live longer. So with that, I'd like to thank Di for joining us from primary care, obviously to all our consultants that have joined us from the One Welbeck team, and perhaps most importantly, our organizer, Rupal. And Rupal will send a video out of this session. And I'd like to finish by saying over to you, Rupal, to close it off.
Thank you so much to everyone who's joined today and the fantastic panelists. It's been a very insightful evening.